hallucination. They could have any delusion, hallucinations. Delusions are abnormal beliefs. They usually describe they are giving me tough time for no reason. You can ask, do you feel that everyone is giving you a tough time for no good reason? Then you would go further. Hallucination is abnormal perception, absent of necessary external stimuli. Visual. So the patient might say that I see people, I see faces. Do you ever see things or people no one else seems to see? So you can ask this question. Do you ever see things or people no one else seems to see? Do you ever see strange things? So you can ask such questions. Do you ever hear voices when there is none there? Do you hear things or voices that no one else seems to hear? Do you ever feel things on your skin or strange sensations? So these are the things would be hallucinations. Sometimes people would say that I feel the smell. So this do happen sometime with the some of the people that I can feel smell of something particular, but there is no smell. Delusion of perception, persecution. The patient may feel spies are after them, or the police are after them. So this is delusion of like that they have done something wrong and are after them, which means they generally don't feel safe. Since police spies have been after you and it's affected your day-to-day life, do you feel safe? Have you ever felt the need to carry a weapon? Would you use a weapon to defend yourself against them? So that's very important to ask. Why did they tell me to go punch people? Usually this means there's a higher risk of self and other. Take a history of this. What do the voices tell you to do? How many voices are they talking to you? How frequently do you hear those voices? Have you thought or attempted to do what the voices have been telling you? What happens when you don't follow the instruction the voices are telling you? Do they get more intense? Background of presenting complaints. Delusions or beliefs can affect their life and impact mood, sleep, relationships, job. They may fear being caught, so they have not left the house. We always assess effects on their jobs, activities, relationships, sleep, sex life. These are the questions you can ask. Job, activities, relationships, sleep, sex life. We also ask about insight and psychosis. Do you feel there's a problem that we as a medical professional can help? Take history. Again, grips. You will start with the grips. Rate the patient and paraphrase. Well, I understand the police bought you. Understand your mother was concerned about you and asked you to speak to us. They may not agree. Argumentative. Not trust you. Offer confidentiality. We are doctors here to find out how we can best help you. You can feel safe here and trust that we would only act in your best interest. And can you please tell me what's been happening so far? You may need to be patient and explore social history because they decide to open up. So be flexible in your approach. History of delusions. How long has it been after you? Do you hear them? How many? Have you ever spoken to them, or they spoken to you, or do they just speak among themselves? Have you ever seen them? Do you ever feel as though people are stealing your thoughts? So same question you can ask again. Social history you can ask again. So background history you can ask for depression, how's your mood, ask for the suicide risk and everything. This is how it would go. Again, this is the same thing. So let's go for the depression approach and we will quickly go through that approach. So let's go with the depression approach. Then we'll do some scenarios from the depression. Could you please show the slides? I will do it again. Let me quickly finish with the depression. So recognize depression. Think about red flags of society. I already told you a few questions about depression. Depression has two main categories. Less severe depression includes subclinical and clinical depression. More severe depression include moderate and severe depression. Also chronic depression, severe depression not responding to treatment. The assessment of severity and management of depression is marked against effect of social functioning, day-to-day life, job problem, looking up the case severity, complex social issues making depression likely to get worse. Okay. And symptoms of depression, first ask the two screening questions. Is the last 2 weeks, have you noticed you feel low or had a feeling of hopeless for most of the time on most days? So you can ask, do you feel low lately? Start with the biological symptoms. Have you lost interest in activities or take little pleasure in doing things? I I just want to ask you about how things have been over the last month. Have you by any chance been feeling low, depressed for most of the time? Have you by any chance lost interest in motivation in doing things? So these questions, low mood, can you scale 1 to 10, 1 being the lowest and 10 the highest? And these are the questions you can ask. These are a few more questions that you can ask: appetite loss, weight loss, sleep problem, wakes up early, sleeps a lot, at what time you wake up early. When you wake up early in the morning, do you feel tired? Do you feel low, lack of concentration, feeling foggy? Do you think the life is hopeful? Do you feel worthless? Sometimes when people go through low mood, they also develop feeling of guilt, worthlessness, or even hopelessness. So I'm sorry to ask you this, but do you by any chance have thoughts, feelings such as these? And again, I'm sorry to ask you this, but sometimes people may also develop feelings of hopelessness or thoughts of harming themselves. Have such thoughts ever occurred? So you will ask that. Depression itself, 2 screening questions you can ask about the DDs: lightheadedness, faints, malabsorption. You don't need to ask more questions, just ask about tiredness and few DDs, especially hypothyroidism. Most of the DDs question overlap with depression questions, so you end up only asking about bowel habits, fever, and cold intolerance. Just stay. The whole idea is that you just rule out the medical problems from the non-medical problem, like the psychiatry is the medical problem, but sometimes you need to rule out from the psychological or psychiatric problem or the simple medical problem. Sometimes few scenarios you would see in which the patient might come with the tiredness, low mood, and insomnia. Takes a usual history. So the presenting complaints could be tiredness, that they will say low mood, and they will say insomnia. Take usual history with the Odipara. Ask about how many times you're having, and other than low mood, otherwise start with the 2 screening question. If body language is down, I can see that you look quiet at the moment. I just want to ask if there's anything going on lately that's been bothering you. So this in the depression scenario, you would see the patient is not doing the eye contact. They are sitting like this, very low. So you will pick up the cue and you'll say, I can see that you seem a bit low. And what can you tell me more about that? Do we need to know how to mental status exam? I'll come to that, Janvi. Just focus now. I'll tell you how to do that. Ask 2 screening question. If yes, take full symptom history. If no, then go to the DDs. So 2 screening question is that I can see that you look quite down. The moment I just wanted to ask, is anything going on lately? Take the biological question of low mood or depression. If no, then go to the DDs and DDs of hypothyroidism and everything. So again, this is the same way. You will ask about red flags, worthlessness, hopeless, and suicide thought. Examination, only thyroid in the scenario when the patient is, you are suspecting hypothyroidism. So treatment-wise, will come with the CBT, medication, follow-up, advice, safety net, leaflet. These are the things we will see. So the CBT, you will talk about the CBT, cognitive behavioral therapy, the short-term form of behavioral treatment. It helps people problem solving, CBT. So that it's a talking therapy. When you come to that, you'll mention talking therapy. It's like situation, thought, emotions. So you will talk about the CBT as well. So these are the few things you just need to know. And SSRI, who to give SSRI, when to give SSRI, you need to mention that. They may take some time to work and you may feel worse before you get better. You start to feel that effect in a couple of weeks, but it can take up to months to feel the full benefit when you'll speak about SSRI. These are the few approaches which you need to know. We'll take a break. And after the break, we will start with doing the scenarios of the depression. We'll do the scenarios of depressions, and I'll show you a few scenarios of psychosis as well. And then suicide risk assessment. Janvi, I'll come to that, suicide risk assessment.